Good morning. I have the distinct pleasure of introducing one of my favorite people here at UCLA, Dr. Katrina DeBonis. She's the Director of Residency Education for the Department of Psychiatry and Biobehavioral Sciences at the David Geffen School of Medicine at UCLA. Originally from New York City, she graduated from MIT, where she studied brain and cognitive science, after which she went on to receive her medical degree from NYU School of Medicine. She matched at UCLA for psychiatry residency training and completed her intern year at Harbor UCLA. She joined the faculty at UCLA in 2011 and has held leadership roles in medical and resident education. Her clinical interests include college mental health, and she's been the medical director of the UCLA Student Behavioral Health Services for almost 10 years. She has published articles on equity and diversity in residency recruitment, physician wellness, and innovations in undergraduate and graduate medical education. Dr. DeBonis is humble by nature, though I had to do some extra sleuthing to discover that she was awarded the UCLA Exceptional Physician Award in 2020, as well as a Golden Apple Award for Excellence in Medical School Teaching in 2018. So Dr. DeBonis is truly an exceptional human being who cares deeply about education, excellent clinical care, and really building community. Personally, she has been a role model for me and so many others since I was an intern here at UCLA, and she continues to amaze us all with her capacity to care, to move mountains, and to never accept the status quo. So please join me in welcoming Dr. DeBonis as she speaks about treating Gen Z, the college mental health crisis in COVID-19.
Thank you so much, Dr. Richards. Let me get my screen up. Okay. All right. So good morning, everyone. I am excited to be giving this talk today on treating Gen Z, the college mental health crisis in COVID-19. As Dr. Richards mentioned, I've been the medical director for UCLA Student Behavioral Health Services for the past 10 years. This is a program that provides mental health care for UCLA undergraduate and graduate students in need of long-term care. And through this work, I have witnessed some concerning trends over the past 5 to 7 years that are starting to be described more widely in the literature, not just at UCLA, but across the country. And these trends, I believe, are important for us all to be aware of in this field so that we can treat members of this generation as they go from childhood to young adulthood and beyond. I have no conflicts of interest to report today. And I want to tell you a little bit about what I hope to share with you. In addition to reviewing the data around the mental health trends for this generation, I will walk us through some of the evidence connecting social media and smartphone use with mental health. I will talk a little bit about what we know so far about the mental health impacts of the COVID-19 pandemic on this age group. I think that there's going to be a lot more coming in the years, particularly probably this year. And I hope to leave you with some ideas, both big and small, for what we can do as a field to better understand and provide the best treatment for the members of Generation Z. When thinking about defining a generation and why it matters, particularly with regards to mental health, I think it's helpful to think about what creates generational differences. Cultures change through mechanisms that include economic, technological, and political trends. And evidence suggests that these cultural forces have a particularly strong impact on young people whose worldviews are still forming. And overall, a growing body of research supports the idea that cultural change leads to birth cohort differences in characteristics such as empathy, sexual behavior, job characteristics such as work ethic and priorities within the workplace, as well as individualism. Cultural changes may also affect psychological well-being, which is something that we are seeing with Gen Z. This provides a very rough overview of what constitutes each generation and some of the factors that have shaped each of these cohorts. We have the traditionalists, who were shaped by World War II and the Great Depression, the baby boomers, who were shaped by Vietnam, civil rights, television, and post-World War II wealth. We have Gen X, also known as the latchkey kids, who were the first generation to have a majority of people where both of their parents were working outside of the home. And this is when computers first came on the scene and they experienced the end of the Cold War. And then the millennials, which experienced a lot of really significant events as they were coming into their worldview. So they experienced the September 11th terrorist attack, Columbine school shootings, Great Recession, and then the growth of internet and social media. So millennials have been the group that have generated a lot of buzz over the last decade, but after tons of articles and criticisms about millennials, the oldest millennial is now 39. We are now starting to understand and look at the next generation. So who is Generation Z? So this is the current group of 11 to 25-year-olds. So middle schoolers, high schoolers, and college students. They are also known as iGen, post-millennials, and recently nicknamed Zoomers. This group is often referred to as digital natives, meaning that the internet and smartphones have been woven into their lives basically from the beginning, whereas millennials and above, they can remember a before the smartphone and after. Millennials often have baby boomer parents, whereas Generation Z is more likely to have parents who are Gen X. Prior to this year, some of the factors that have been shaping this generation were smartphones and social media, as well as school shootings, the threat of climate change, and political division. And now, of course, this generation has been living through the COVID-19 pandemic, as we all have, but we know that younger people are going to be shaped by this in a different way than everybody else. In defining Generation Z, diversity is one of the biggest characteristics. This is the generation of greatest diversity on many different levels with regards to ethnicity and race, as well as sexual and gender identity. Here we are seeing data from the 2020 census, which was just released a few weeks ago. You might have seen some of the data come out in the lay press. And as it was predicted, the percent of the US population as a whole that identifies as white dropped to 60%. So that's what you're seeing right here. And for the section of the population that's 16 and younger, it's now at 49.95%, below 50% for the first time. The past decade, from 2010 to 2020, is the first decade since the first census was taken in 1790, when the white population did not grow. With regards to sexual identity, in a Gallup poll in 2020, this is of US adults. So of Gen Z adults, 15.9% self-identified as LGBT. The question that was asked in this poll is, which of the following do you consider yourself to be? People were able to select as many as apply: straight or heterosexual, lesbian, gay, bisexual, transgender. So you can see here 15.9%, which is a significant increase from the prior generations. And when you look at that a little bit more, you see that the vast majority of Generation Z adults who do identify as LGBT, 72% identify as bisexual. So 11.5% of all Gen Z adults in the US say they are bisexual. And you can see that this is a huge jump from prior generations, whereas people identifying as gay or lesbian or transgender, you don't see that same big increase. And although we do not have great data yet on the representation of Gen Z when it comes to gender identity, this survey in 2018 indicated that members of this generation are more likely to know someone using gender neutral pronouns and are more likely to say that questions on forums asking about gender identity should offer other options other than man and woman. Some literature in this area has observed increased trends in this generation towards seeing gender as a spectrum and non-binary. But I think that really we need to have more concrete data in this regard. So we know that Generation Z is more diverse, and there's a lot of evidence to suggest that they also are likely more tolerant. But what about their mental health? So what we are looking at here is data from Monitoring the Future. This is a large nationally representative survey of American 8th, 10th, and 12th graders. And this has been conducted every year since 1991. And we're looking here at self-esteem and happiness. And so what we see is that after staying steady or rising between 1991 and 2011, that adolescent psychological well-being dropped noticeably between 2012 and 2016. So here in self-esteem, you see it's kind of hanging in there. And then right around 2011, you see this drop. Whereas with happiness, there was this incline and it kind of stayed around here. And then similarly, right around 2012, it started declining. So the effect size for this decline between 2012 and 2016 ranges from about 0.07 to 0.24 with an average of 0.14. And although this is traditionally considered a very small effect size, it must be understood in the context of a pretty brief period over which it occurred, really just 4 years. And so this is an unusual amount of change for a short period of time. During this same period of time, we're seeing a decline in alcohol use, a decline in sexual activity, and a decline in this question on the survey that asks how often these kids are going out without their parents. So as you kind of take this data all together, there's this decline in measures of psychological well-being. There's also this decline in some of the activities that are traditionally associated with adolescence and young adulthood. And so those are the trends that we're seeing in middle schoolers and high schoolers. And then over the same period, looking at college students, we see that from 2010 to 2015, we saw this huge explosion in mental health utilization across college campuses. And we experienced this here at UCLA, and it was mirrored across the country. So 30 to 40% increase in utilization with a corresponding increase in enrollment only by 5% over the same period. And what we're seeing is this increased prevalence of serious concerns, such as threat to self indicators. And we're also seeing that the people who are entering college have higher rates of experiencing treatment previously, and that the rates of self-reported anxiety and depression are driving the trends that we're seeing. So to look at this graphically, students are entering college with higher rate of prior mental health treatment. That's what we're seeing here, prior rate of counseling, medication, or hospitalization. The hospitalization numbers increase and then have kind of hung out at this higher level than they were before 10 years ago. And then these threat to self indicators, non-suicidal self-injury, serious suicidal ideation, suicide attempts, and some suicidal ideation present in the past 2 weeks, all of these have been on the rise. And so taken together, these trends indicate that the population as a whole is not just using more services. Initially, when we were seeing this explosion in utilization, people were wondering if this was a result of destigmatization and increased access. But I think what we're really seeing is that this generation, these students are in fact struggling more, including with some serious signs of mental health struggles, including serious suicidal ideation. Anxiety and depression are the most common concerns and have demonstrated a lot of growth over the past 10 years. So you see here, depression, generalized anxiety and social anxiety have been driving this increase, whereas things like academic distress, eating concerns, hostility, family distress have stayed somewhat constant. Substance use has actually declined with the exception of marijuana use, which has increased. And looking at the suicide data over the past 20 years, we have also seen some very concerning trends. So here on the left, we see males, and then on the right, we see females. The total age-adjusted suicide rate has increased 35.2% from 1999 to 2018, before declining just a little bit by 2.1% in 2019. And so for both males and females, the suicide rate in 2019 was lower than the rate in 2018. And so the data we are seeing so far for 2020, which we were really worried about, has not shown an increase in suicides overall, which is good news. But looking specifically at trends in young people, here in males, we see that among the 15 to 24-year-olds, that's this curve, we saw a significant decreasing trend from 1999 through 2007. And then a significant increasing trend from 2007 through 2017, with it stabilizing after that. Among 10 to 14-year-olds, we saw, again, a decreasing trend from 1999 through 2007, and then a significant increasing trend from 2007 through 2019. For women, for ages 15 to 24, there was a stable trend from 1999 through 2007, But then, as you can see here, a pretty significant concerning increasing trend from 2007 through 2019. So you can see that that rate of increase is higher for women than it is for men. And among ages 10 to 14, we also see a significant increase across this time period for women. So although men continue to commit suicide at rates higher than women, you are seeing that the increase from 1999 to 2014 was much greater for women than for men. And you're seeing, unfortunately, increases across all these age groups except 75 and over. So this takes us to why. Why is this generation so depressed and anxious? As a society, we try to find things to point to when there's something wrong and say, that's why. We have blamed violent video games for school shootings, and we blame social media and smartphones for anxiety and depression in young people. And now we're blaming COVID-19 and school closures for mental health concerns. And I hope to make it clear that I think it is much more complicated than any of that. Although there has been a lot of attention recently on COVID and school closures and how it's affecting young people's mental health, it is very clear from the data that I just showed you that these trends were already occurring. There will be much more data to look at over the next year, so understanding the full impact of school closures and the pandemic on this generation's mental health will be better understood with more time, but I will share what we know so far. So first, I will provide an overview on some of the social media and smartphone data, and then move into what we are seeing with impacts from COVID-19. So this is not surprising. At this point, 95% of teens report that they have a smartphone or access to one. And back in 2018, 45% of teens were saying that they were online on a near constant basis. So this is the reality for our teenagers. In the UK in 2018, the Secretary of State for Health and Social Care issued a warning on the potential dangers of social media on children's mental health, stating that the threat of social media on mental health was similar to that of sugar on physical health. And when public concern rises like this, it really falls to the scientific community to provide and assess the evidence and make recommendations. And this has been challenging for many reasons. So in this study in 2017, Przybylski looked at mental well-being as a function of daily digital screen time on weekdays and weekends. And so they split it up into time spent watching TV and movies, video games, using computers, and using smartphones. And so you can see that there's a U-shaped relationship here for all of these activities, where no activity is actually worse than a little bit of activity. Where you see the clearest negative impact is when you get into higher levels. So for smartphone use, that seems to be past the 2 hour per day mark. So here you see 0, you see there's actually some benefit from 0 to 2. And then after 2, you see kind of a dose response negative impact. So the more time spent on the smartphone, the more of a negative effect it's having on mental health. And in a couple of years after that study, the same author, Przybylski, examined 3 large-scale data sets, 2 from the US and 1 from the UK, that included information about teenager well-being, digital technology use, and other variables. And in this study, they ran all theoretically plausible analyses, combinations of dependent and independent variables with or without covariates, and overall found a statistically significant negative association between technology use and well-being, that more screen time was associated with lower well-being in the young people surveyed, but the effects were very small. And so small that it was explaining a very small 0.4% of the variation in well-being, that it was determined to be of little practical value. Well-being was found to have much stronger associations with other variables such as binge drinking, being bullied, smoking, getting enough sleep, eating breakfast, even things like eating vegetables, wearing glasses, or going to the movies had a stronger effect on well-being compared to digital screen time. And so their analysis concluded that when viewed in the broader context of the data, that it becomes clear that the outsized weight given to digital screen time in scientific and public discourse might not be merited on the basis of the available evidence. For example, in all three data sets, the effects of both smoking marijuana and bullying had much larger negative associations with adolescent well-being. And in this study, using population-based data from the UK Millennium Cohort Study, which was one of the studies used in the other analysis, this is 10,000, almost 11,000 14-year-olds were used to examine the associations between social media use and depressive symptoms. It's important to note that the magnitude of association between social media use and depressive symptoms was larger for girls than for boys. So in this graphic, the width of the arrow indicates the strength of support for that pathway. So the most important routes from social media use to depressive symptoms are shown to be via poor sleep, as well as online harassment. There was a simple pathway from social media use to depressive symptoms via poor sleep, whereas the role of online harassment was more complex with multiple pathways through poor sleep, poor self-esteem, and through poor body image, resulting in depressive symptoms. I want to spend a little bit more time talking about this association with sleep because I think that there's something very important here. There's been a growing body of literature surrounding social media use and its effect on sleep quality and mental health in youth. It's commonplace for young people to sleep in close proximity to their phones, adults too. And sleep has this clear link with mental health. So social media use could impact young people's sleep in multiple ways. So for instance, spending a long time on social media might lead to reduced sleep duration, and then incoming alerts in the night and fear of missing out on new content also causes sleep disruptions. Screen exposure before bedtime and the consequent impact of this on melatonin production and the circadian rhythm are also possible mechanisms. Sleep quality and quantity could also be affected by levels of anxiety and worry resulting from experiences of online harassment, particularly right before sleep. In a recent review of this topic, some studies showed that sleep quality was really what was mediating the relationship between social media use and negative mental health outcomes in youth. I think that one of the interesting things to note that, our screens have a high amount of blue light in them, which result in melatonin suppression, which can result in circadian rhythm disturbance, sleep disruption, and depressive symptoms. And that melatonin suppression is greater for children compared to adults. There's a few studies that I saw that looked at using blue light blocking glasses in teenagers and showing that that did seem to mitigate the degree to which melatonin was suppressed, which you really don't want to happen right before bedtime. So I think these are some of the really interesting areas that we could be exploring more and also weaving into our clinical recommendations. When you ask teenagers, they have mixed views on social media's effect on people their age. About 30% say mostly positive effect, 45% say neither positive nor negative, and 24% describe a mostly negative effect. So altogether, smartphone, internet use, and mental health has a really unclear relationship and strength of effect. The studies have mixed results, and the magnitude seems to not be that large. These are all real correlations that we're seeing, not clearly causal. There's some data to support that social media can enhance teen relationships and that virtual communication can help adolescents bounce back after social rejection. And so it's clearly not all bad, not all good. One of the things that I think that we don't understand as well, that I think we need to, is that it could be worsening some pre-existing vulnerabilities. So when we're looking at the population as a whole, we might not be picking up on this strong effect, but if we were looking at kids with more risk factors, we might see a different story. So in general, the adolescents who encounter more adversity in their offline lives seem more likely to experience the negative effects of using smartphones and other digital devices. In a 2015 North Carolina survey, teens from low-income families were more likely than more affluent peers to report that their experiences on social media resulted in offline physical fights, face-to-face confrontations, or them getting into trouble at school. This effect has been termed social media spillover. Adolescents who have a history of victimization are more likely to be bullied, solicited, and victimized online. And those with behavioral problems, such as difficulties concentrating in class or a propensity to get into fights, tend to experience more problems on the days when they use digital technology more heavily. In some of the UK data, teens from low-income households and from single-parent households are more likely to spend 5 or more hours per day on their phone. And it's clear that that level of use does seem to be linked to poor mental health outcomes. So I think of this as, and some of the terminology in the literature is the digital divide, that there's a lot of adolescents who are, for the most part, happy, well-adjusted, have friends, are doing okay socially, going through normal teenage stuff. And for those kids, spending time on their phone might have this minimal impact on their mental health. But for kids who are at risk, who are having stressors at home, who have behavioral problems already, that same amount of time on their phone is likely causing a more significant impact on their mental health. And so this is what I think we need to really be parsing through in our studies, is looking at those risk factors and seeing how that intersection between those vulnerabilities and screen time is affecting mental health and what interventions might be helpful. Now, switching to COVID-19 impacts on this generation. In order to rapidly monitor changes in mental health status and access to care during the COVID-19 pandemic, CDC partnered with the US Census Bureau to conduct the Household Pulse Survey. And this report describes trends in the percentage of adults with symptoms of an anxiety disorder or a depressive disorder and those who sought mental health services. And so from August 19th to 2020 to February 1st, 2021, the percentage of adults with symptoms of an anxiety or depressive disorder in the past 7 days increased significantly from 36.4% to 41.5%. And the increases were largest among the adults ages 18 to 29 and among those with less than a high school education. And so these findings are consistent with the results of surveys conducted early in the COVID-19 pandemic that show this increased prevalence of mental health symptoms, especially among young adults. And so what we're seeing is that there's been this increase in anxiety and depressive symptoms, particularly among young people, and that increase has persisted throughout the length of the pandemic. And overall, mental health conditions are disproportionately affecting specific populations, young adults being one of those. But in addition, Hispanic persons, Black persons, essential workers, unpaid caregivers for adults, and those receiving treatment for pre-existing psychiatric conditions. So young adults can exist in multiple of those categories. And some of the observations from surveys across the country, as well as across the world, are observing increased stress, anxiety, and depressive symptoms. It's not very surprising given what we're seeing and what these young people are experiencing. And some of the causes that young people are identifying as contributing to those increase in symptoms include changes in school, social isolation, decreased family income. Members of this generation are more likely to have had someone in their family laid off from their job or had negative financial impact, and as well as their future employment. This is definitely something that I'm hearing a lot from the students I'm treating, that they're really worried about their future. And this is observed not just in universities here in America, but across the world. And among the most commonly reported changes were this lack of motivation, in addition to the anxiety, stress, and isolation. People are, and again, I don't think that this is hard for us to imagine, feeling less motivated to work hard at school, and they're linking it to the uncertainty of their futures. Some of the other risk factors that we're seeing for these psychological impacts. This is a study looking at university students across 7 states here in the US. And in the multivariate models, controlling being a woman, being 18 to 24 years old, having poor or fair general health, reporting more screen time, and knowing someone infected with COVID-19 were statistically significant risk factors. Low socioeconomic status, as well as identifying as non-Hispanic Asian, were additional significant risk factors in the subsample of respondents obtained from representative sampling. So in summary, Generation Z is really demonstrating these high rates of anxiety, depression, and suicidality. We're seeing that members of this generation are drinking alcohol less, are engaging in sexual activity less, and there's less independence in general from their family. And what we're seeing is an increased utilization of mental health resources at college campuses across the country. And this was all happening before COVID-19. And now that we're seeing that COVID-19 is disproportionately impacting this generation's mental health, that although these trends were pre-existing, it's hitting them harder, and particularly groups with higher risk factors. And when we look to the smartphone and social media use, I think what we're left with is this really unclear correlation to mental health. But what does seem clear is that disruption in sleep may be a strong contributor in a pathway from smartphone and social media use to poor mental health outcomes. So some of the things that we can do as in our field, both clinically and in terms of research, I think that there's a lot. So I would encourage us all first to be critical of the media hype. I think there's a lot out there in general that is making us contributing to our fears about how school closures and COVID-19 are going to affect this generation, as well as smartphone use. And it leads to people making choices for their families and people putting out policies that might not be based in evidence. And so I think it's really important for us within the field of mental health to be critical consumers of the research and the media hype, and to be advocates for this generation for what we should do so that people aren't left kind of with these over responses to some poor data. I think psychiatrists, neuroscientists, and computer scientists can help us together better understand the intersection between the developing brain and social media and smartphone access. I think one of the areas that is particularly interesting, which I've hinted at, is this exposure to light and the effects on the circadian rhythm and the developing brain. If we know that melatonin is suppressed to a higher degree in young people, then that has a lot of downstream effects in terms of circadian rhythm as well as mood. And so measures such as whether or not young people should be changing their habits with their smartphones, particularly in the evening, versus wearing blue light blocking glasses. All of those things, I think, are things that are real good questions for us to be asking, and for us hopefully to be able to develop some evidence to support either using or not using, so that we can guide our patients as well as parents. And we really do need to develop a more nuanced understanding of psychological risk factors and effective interventions to reduce risk. When we're looking at young adults or kids who have these behavioral problems that we know or starting to understand provide a vulnerability to excessive smartphone use, how do we as a society, from a public health standpoint, as well as from kind of an individual clinical standpoint, help people be able to mitigate those risks? I have a few things that I've been doing that I from my own observations, my own clinical work with this group of people, but there really hasn't come out, there haven't been guidelines out on how to have these conversations, what we should be asking for, what should our routine screening be, the way that we have more guidance in terms of other things like exercise and sleep in terms of mental health. We need to be able to provide our patients with guidance on how to responsibly use their devices in order to not have more negative effects on their mental health. And in terms of these clinical guidelines, I think that there's a lot that we can do to incorporate generational changes into our clinical practice. when we're asking questions regarding identity, most of us learn to do this in a very different way. And we need to change the way that we're asking these questions. We need to be open, we need to be non-judgmental, we need to resist assumptions and labels. And I think the cultural formulation interview that was part of the DSM-5 provides a nice language for us to be able to ask these questions in a more culturally humble way. I think that we need to start asking about computer and smartphone habits more routinely. I've started incorporating it into my review of systems. So I ask about appetite and sleep and energy and concentration. And I ask about people's smartphone habits. Sometimes I will have them show me their screen time use. And I will use that clinically to help them make connections between how they're feeling in terms of their depression and anxiety and the amount of time that they're spending on their phone and which apps that they're spending the most time on and which times of day they're using their phone. I also have started involving their smartphone in safety planning and mood regulation. So I'll have conversations with my patients. When you're feeling this way, when you're feeling depressed or when you're feeling anxious, what does that tend to do? What do you tend to do with that? Do you tend to spend more time scrolling social media? How can we help you to use your smartphone in a more mindful way? That's a term that I've been using, so that when they start looking at their phone, they ask themselves, what am I looking for? How am I feeling? What might help me to feel better? As opposed to this passive scrolling, this passive kind of distraction away from their feelings, that they can kind of use it in a way that might help them feel better, if it's texting a friend or if it's listening to music or looking at certain things that do help their mood. I think that the sleep component is something that we also need to be spending a lot of time on. For anybody with any sleep complaints, we should be trying to understand how the use of their smartphone might be intersecting with that. I have a lot of patients who won't describe it until I start to dig deeper, who will basically be watching YouTube videos until they fall asleep. And then when they wake up in the middle of the night, because they have disrupted sleep, they need to put on the YouTube videos back on. And that's their pattern. And it's leading to a significant disruption in their sleep quality, and probably corresponding to some of their mood and anxiety increases, and connecting those dots for them and helping them to undo some of those habits often will lead to improvements in their overall condition. We need to be thinking about how to cultivate resiliency amidst the very real stressors that this generation is experiencing, COVID-19 being one of them, a big one, but the insecurity over their future is very significant, related to economic forces as well as things like climate change. And in these conversations that I'm having with my students, I see that these are real concerns that are generating understandable anxiety and sense of hopelessness. And so although I don't think that I have necessarily the answers to help this generation get through these times, I think we can use our knowledge of how resiliency is cultivated, and how that's has applied to other difficult times in history, and helping these students while they're living through it, making sense of it, trying to make meaning of it, processing their grief around the things that maybe they thought were going to be part of their future, or how college would look or what life would look like, and understanding how they might need to shift and adjust. I think the idea of narrative building it can be a really powerful one for them. What stories are they telling themselves about their lives and what their lives are going to look like, and how can we play a role in helping them shape a narrative that helps them access their strengths. And then I think one of the big things that I hear a lot and that I felt a lot for myself too is this idea of generational transference. This is my own term. I'm not sure if it's something that's out there, but I think what I'm referring to with this term is this negative experience that providers can have when working with members of a different generation, and also just members of a different culture in general, that they feel like maybe they don't understand, that they don't get, that they might have negative feelings about some of the differences in collectivism versus individualism, in their priorities that they have in the workplace and how that might be different from older generations. And for some of the differences in how they're approaching identity. I think it's really important when we're trying to build therapeutic alliance with our patients to be curious about these changes rather than to have, we might have these senses and feelings of, oh, this isn't right, or this is different, or it was so different when I was growing up. And I think it's important for us to be aware of those feelings and to check them in order to avoid empathic failures. I have to say, for doing this work for the last few years, I have come to really feel for this generation and really find them to be so strong in so many different ways. And I have so much hope for what they might be able to do for all of the different challenges that our world is facing. And I see our role in mental health as really important. If we can help this generation stay as well as possible mentally, then they'll be in the best position possible to make use of their strengths, to make use of their education. This is the generation also of highest degree of education to be able to solve the problems ahead. They won't be able to do that if the depression and anxiety persist at this level. So I think that there's a lot for us to do in our clinical work, but I would also love to see some of this data that we're seeing be translated into the public health sphere, because I do think, I've seen a lot of hype in the media about the mental health pandemic of this generation. And again, a lot of fear-based things, but I would love to see that translated into interventions in some of our institutions, middle school, high school, college, that really are geared towards helping promote strength and resilience for these young people. And so I'm going to pause here and take questions. Thank you so much for your attention today, and I hope that this was helpful for you.
Thank you so much, Kat. That was so interesting. I think many of us in the audience have multiple questions, and you can probably see in the Q&A, there's a few, and I'll read some of them out loud. And Kat, if you have a moment, I'd love to hear your thoughts. If you have any more questions from the audience, please just go ahead and submit. We have about 15 minutes for questions. So the first one comes from, let's see, well, actually it says, for 16 to 24-year-old women and suicide, did you adjust for SES going to college versus not? Why lump teenagers and college students and beyond?
So for that data, this is nationwide data, and I don't know if any subsequent studies have broken it out into socioeconomic status and going to college or not. I think that in general, having not gone to college is independently a risk factor. And I think what we're seeing in general is that socioeconomic status is, particularly now during the COVID-19 pandemic, has been an additional risk factor. But that's the best answer I could provide for that data. I think that, when people are asking themselves the question, why are women having this increased growth of suicide, unfortunately, and including in this young age, but also all ages for women, there's a few hypotheses out there. None have been kind of confirmed, but in one of the graphics that I showed you in terms of the path from smartphone use to depressive symptoms, there does seem to be this link that is stronger for women in terms of the amount of time spent on the phone and body image dysphoria. So I do think that is a finding. The degree to which it's contributing to these other things is unclear.
Thanks so much, Kat. It is a very interesting topic in general. Certainly COVID-19 has been on all of our minds. Really like how you're talking about collaborating with patients and working with them and being curious as opposed to mandating. And this is what you need to do, and kind of that joining process. Someone else asked, has anyone shown that blue light filter on phones makes a difference? Thank you.
Yeah, so for everybody who might not be familiar with this, most phones have the ability to go to something like night mode, or you can do night mode or black and white, where there's less blue light being transmitted during those times. And so you can set your phone under settings to do that automatically. You can set the hours at which it goes into night mode. And this is something that I do with my students. We'll do it right there in the office. I'll take a look at their phone. I'll help them set it. I don't know if the blue light filters on the phones make a difference, but I have seen studies that the blue light blocking glasses at night do make a difference. So the one study that I'm thinking of, it looked at, I think it was 15 to 17-year-old boys specifically, and they wore the blue light blocking glasses basically from early evening to bedtime. And so compared to the ones that wore just regular clear glasses, the boys wearing the blue light blocking glasses had less melatonin suppression, which I mentioned, but they also felt sleepier when earlier. So it did seem to translate over to kind of clinically significant differences for less alertness and things like that. So I think it's really important. And I think it's something that we just really haven't appreciated. I think we adults experience this also, but it seems like to a lower degree than kids. And so I do think that we have to be more careful about the light exposure that our kids are getting, particularly from the screens in the later part of the day. I think in terms of the specific question about the phones, I don't know if it works, but I think you can feel it. So if anyone's made this change, you can feel that it looks more dull. And that's a good thing. Like you want it basically to be a little bit less activating at night. And so my hunch is that it works, that it's probably better than nothing.
Thank you. Yeah, I have that setting on my phone, and it's like an orange hue, and It does feel a little bit more calming at night. Another really good question is about melatonin. Since melatonin is suppressed from blue light, would it make sense to supplement with melatonin? It may be easier to convince college kids to take melatonin rather than to put down their phones.
Yeah, I think that's really an interesting point. And I think, again, it's like a harm reduction model. So I think in general, I would promote trying to develop a different habit with your phone. I think that there's evidence to suggest that if your phone is in your other room, or at least not next to your bed, that you will sleep better. So talking about those things, but realistically, probably not going to do that, right? And so then I would kind of try to do the night mode, maybe try to do the blue light blocking glasses. In my experience, having these conversations with students, as long as you're not like, you just need to get off your phone. You need to not have your phone. If you're actually talking about blue light and melatonin, and they're interested and they want to kind of like, have a life hack around this so that it's not affecting them in this negative way. They're very interested in it. I think it would be, I don't know actually what the effect would be. As I'm thinking through it, it's like you're suppressing melatonin and you're supplementing with it. Again, it's probably better than just having the suppression, but it might be altering the circadian rhythm in a different way. And so I would definitely recommend it, but I don't know what the full effect of that would be and if that would mitigate some of the negative effects that we're seeing. I think that there is some evidence to suggest that the amount that we give in terms of melatonin, because it's not FDA regulated, it's an over-the-counter supplement, it might be too high for kids. And so I think that's also another area that you would want to try to figure out, like, what is the right dose if you are going to supplement it so that you're not having unintended negative consequences.
Thanks, Kat. And here's another question. What are your thoughts on how to best check in with how high school students and college students are doing? I've had feedback from college students I'm currently mentoring that their routine weekly check-in mental health surveys sent by their schools are contributing to email fatigue, especially on top of the number of emails they're already receiving from their virtual classes.
Yes, this is a great question. And I think we all can kind of feel this, the survey fatigue is real and is probably not as meaningful as having an actual one-on-one session with someone. And so it's definitely easier to just push out a survey, right? But I think we're probably not getting the data that we really need to get. I was thinking about this in preparation for this talk. I think I would probably recommend something like routine, scheduled one-to-one visits for check-ins as opposed to these surveys. I think that it allows for an opportunity to get a lot more helpful information, but of course it comes at the expense of the ease. You need people to be able to do these sessions, but I have a feeling that if we could ramp that up, that it would be a much more helpful intervention than the surveys.
Like that connection piece, like that.
Exactly. You would be able to have follow up with questions, be able to flesh things out, being able to discuss things a little bit more, and then be able to guide them towards the most appropriate resources.
And maybe just a few more questions here. How do you directly address the lack of motivation, both academic and social, among your patients? And then it says, I'm seeing this problem among many of my adolescent patients as well.
Yes, I think from the articles that I've seen more targeted towards adults, the same phenomenon is happening, right? This languishing effect. I think this is a difficult time to be feeling motivated and excited to be working on things for the future. And it is very, very real in our students and Gen Z as a whole. So I will say what I do. I don't think that I've seen great guidance out there from a in the literature standpoint. But I think what I have tried to do is you can't sugarcoat or try to make it seem as though it's less serious than it is. I think it's kind of accepting the reality of it and validating their concerns, and then also helping them to then move past that and to find the internal motivation to do something, anything. And so I have a couple of tactics that I use when working with this patient population, depending kind of on where they are. So one of the things is kind of this increased, trying to develop this increased emotional awareness. Helping them to kind of pause before looking at their phones or distracting away or numbing out, because I do think that that's kind of what people are doing, again, because it is just a lot of very difficult stuff that they're dealing with, and helping them to kind of stop and say, like, checking in with themselves. How am I doing? What's going on for me? What do I need? And how might I be able to give this to myself? I think that for one thing that I love about this patient population is they really are trying to line up what they're doing with their value system, and they really do care more about like the collective good than kind of their individual stuff. So trying to utilize that and to kind of engage with them in conversations around kind of what is most meaningful to them and how could they try to access that in the world and build on that and connect to other people who share their values, because I think that can help provide them with a little bit of a life raft that they can hold on to as they're kind of going through these times. And I'll see people kind of spark up once we start kind of channeling it into that.
Yep, thank you. That's a tough question, a really beautiful answer, just about reflection, how powerful that can be to be like, what are your values? Which I'm not sure many people have thought about as they're trying to navigate COVID. And then how are you living, honoring your values? And sometimes if you kind of go too far from that, you can feel that burn, that burnout, and that just.
Yes, and I think that's where they already are. They're having this kind of like existential angst of again, it's hard for me to imagine what it must be like being that age and coming into the problems that exist right now in the world. It's really a heavy burden. So I really do. I try to understand it as much as I can before throwing out things that they should try to do, because I think without that, me kind of trying to get into where they are and how they're seeing things, I think it's really easy for advice or recommendations to come off as, like trite or like you don't get it really, or, that's too naive or out there, and so I think it really does kind of require you to see things from their viewpoint while also having your own experience and wisdom to be able to share with them to help kind of get them not stuck in that existential angst.
That's great. So another question is, any app types being used that come as a surprise?
Ooh.
Huh.
There's always surprises with young people. I'm always learning a lot. I'm always Googling new slang. It's always fun for me. I always find out about the new dating apps before most of my age peers. But I can't think of any app types that are really come as a surprise in a concerning way for me. I think, again, what I have noticed, and there is some data to support that, for example, like Instagram has more of a negative mental health effect than Facebook. There's studies that have shown this. And so you can, set up your phone to basically be able to track your time spent on different apps, and being able to kind of curate and say, like, let's get rid of these, or let's spend less time on these, and trying to, again, help them use it more mindfully, where it's like, okay, when I'm feeling this way, I usually do this, and then I feel worse, asking them, like, well, after spending like an hour on that, do you feel better? The answer is like, no, usually not, definitely not. And it's like, okay, well, what might make you feel better? And so sometimes it's things like, I'll have my students, again, collaboratively, they'll create like a Pinterest board of things that they found that kind of cheer them up or give them perspective. Things like watching like Humans of New York, or like feel good stories, like so that when they feel a certain way, they know that they can turn to something in this more mindful way that allows them to maybe see things a little bit differently, as opposed to just kind of feeding whatever mood state that they were already in.
Yep. Okay. Thanks, Kat. One last question here. It's a practical one. Can you lay out a simple referral recommendation? College students accessing services is not easy. Most have to navigate themselves because they are adults. College free resources are short-term and for those who are using the college insurance. If a college student has insurance, the list is overwhelming, I've been told. Do they seek out an MD, PsyD, PhD, MFT, LCSW? Whew.
That's hard to know without knowing the kind of specifics of the referral. But I would say that there are now more, again, I think because there's been this explosion of need on college campuses, there have been some kind of novel group practices that include psychiatry as well as therapy that are not part of school-based services. Like, for example, we have Acacia here at UCLA that is basically designed to support this age. So they're therapists and they're psychiatrists. It's all kind of designed for college campuses. And this is kind of existing on a few different college campuses across the country. And I think that they do a pretty good job. And I think that model is a very compelling one. It's like, designing services specific to this group, recognizing that it is very, very difficult to get them to, it's difficult for an adult to kind of navigate the referrals and find help for themselves. And so for college students, it's almost impossible. So being able to kind of make that as easy as possible. And once you're there in the system, to be able to kind of access the services you need, I think is a very important thing. And I think it's something we should be doing more of.
Okay. Well, thanks so much, Kat. We all enjoyed your talk. I'm sure everybody's screaming in the background and clapping.
Thank you, Dr. Richards.
Yeah.
All right. Thank you, everybody.